Dr. Thomas Yadegar, ICU Director, Providence Cedars-Sinai, Tarzana Medical Center. Obviously, this guy is no slouch. He is worth listening to. He's a pulmonologist who says he has some important information to share with the public and doctors around the world. Welcome, Doctor. How are you?
I'm well, Glenn. How are you doing?
Good. I appreciate you having the guts to come on and possibly say things that some people don't want people to hear. It's weird, this situation that we're in right now. How can you help us navigate?
Well, we've been treating patients for probably about 6 to 7 weeks. And the first few weeks, our experience was the same as everywhere else, where patients were coming in. They were becoming very ill on the floor. We really couldn't figure out why. We had to put them on ventilators. And before very long, I just saw more and more patients in my intensive care unit. And the thing that was very concerning was that, one, I didn't really understand what the process was that was causing them to get so sick. And two, what was really unusual was that it almost seemed like every single patient had a different type of a disease process. Yes, they had what we thought was pneumonia. Yes, they were on a ventilator, but they weren't necessarily acting the same. If I can take you back to 10 years ago when we had the H1N1 epidemic, at that time I may have had 10, 15 patients that were on ventilators. But I can go into each room, and each of them had the same kind of pathophysiology. Maybe they were at a different stage of the disease, but essentially it was the same disease, which caused us to be able to predict what was going to happen. In these types of patients, there's really no predictability to it. Everyone does something that's unique to themselves, and that's what makes it so difficult to treat because, you have no idea what's going to happen the next day.
That's kind of scary. Is there another disease like this or another virus like this?
I've been a pulmonary critical care doctor for 20 years, and I've been the medical director for over 10 years. And no, I have not seen this before in my experience.
So
I've been dealing with respiratory
So that would
infections.
make it... Go ahead.
I've just been dealing with respiratory infections of all types of viruses, bacteria, even fungal infections. There's always some sort of predictability. There's always some sort of a disease pattern. Once you recognize the pattern, you can make the diagnosis, and then you could predict what's going to happen, and you could start a treatment plan, which, will hopefully help the patient. In these types of patients, there really isn't any predictability.
So doesn't that make this harder to treat? And wouldn't that say, don't go to work? Because we don't have a handle on it.
I guess. I guess it depends on where you're coming from. I was initially I trained in the 1990s in medical school in my internship. That was during the HIV pandemic, and to many different factors, this kind of reminds me of that. There is a lot of fear, and unfortunately, that's what we've kind of fed into, as opposed to science and fact and logic. And, people don't want to necessarily go into the rooms and treat these patients and see them, which I can understand. That I've spoken to many doctors, many nurses, and some of them, not so much for the fear of their own lives, but some of them have spouses that are on, that may have had transplants or on immunosuppressive therapy, and they're just concerned that, not only can I die, but I can take something back home to my loved ones and hurt them. And that's not an unusual thought. The same thought went through my head as well. I think that's normal. But you just have to say, okay, but I'm a physician, I'm a nurse, I'm a healthcare provider, I'm trained for this. I'm going to do the best possible to protect myself, and I'm going to do everything possible to protect my family. But I have to treat these patients. Someone has to treat these patients.
Okay, so you've just been asked to command, regionally across 4 more hospitals because you are performing way above, you and your team, above any of the hospitals in the Los Angeles area. You haven't lost a single patient. No one has had to go on a ventilator. And you say that you have a protocol where you can find certain markers and you'll know who will crash and who won't.
Well, first of all, under normal circumstances, there's 20 physicians that I supervise, and we take care of patients at 2 different hospitals. Usually on a daily basis, we take care of 100 to 125 patients, about 30 to 40 of them that are in the intensive care unit. I work both at Providence Cedars-Sinai Tarzana Medical Center as well as West Hills Medical Center, although I'm not speaking for any entity. This is just my personal observation. I just want to make that clear.
Sure. Okay. Yeah.
But that's our normal team that we normally take care of patients. And initially what was happening was, again, patients were coming into the hospital, they were getting sicker, we're putting them in the ICU, and I just thought, okay, I don't understand what's happening. So I started reading, I started researching, and one of the things that I first came up with was that these patients are having what's called a cytokine storm syndrome. And this is a very rare.
That's what happened in 1918 with pandemic as well, did it not?
I believe so, although I'm not sure at that time that we had the technology to really find out exactly what was happening on a molecular basis. But in this syndrome, what happens is that the patients that get very, very sick, the immune system normally mounts a response, right? So if you get a bacteria, if you get a virus, it activates your immune system, and then the immune system coordinates its activity so that it can destroy the virus or the bacteria. But in a subset of patients, the immune system kind of goes awry. It doesn't act normally, and the immune system gets super ramped up, and instead of attacking the virus, it starts actually attacking the patient's own vital organs. So what I started noticing was that, these patients that are going on the respirator, these patients that are what we thought was the virus was causing pneumonia, no, these patients that are coming in and really suddenly becoming so sick, it's actually their own immune system that was causing the problem, not necessarily the virus. Now, don't get me wrong. This is a deadly virus, and just like an influenza virus, it can definitely cause pneumonia. It can definitely cause respiratory failure. If patients have emphysema or heart failure, it can definitely exacerbate those and lead, to them to get into the ICU for those diseases as well. But this was doing something unique. This was doing something that I really hadn't seen much in my 20 years, where it was activating the immune system, and then now the immune system was causing all the destruction in the lungs, not just the virus itself. So in a way, this SARS-CoV-2 causes kind of 2 different clinical diseases. The first part of it is an infectious disease where the virus is a deadly virus and can seriously do some harm. But then the second, and I think this is probably the more important part, is it causes this activation of the immune system. And it doesn't cause it in all the patients, but it causes it in a subset of the patients that get hospitalized. And these are the patients that we found were coming into our ICU. The majority of the patients went in our ICU. And once I started noticing this, I started looking for markers. And these are many markers.
And how difficult how difficult is to find the markers, and can you be tested for that easily, or?
Yeah, these are not any unusual markers. Actually, a lot of the hospitals are checking the markers. But the problem is that there's about 6 or 7 different markers. Some of the markers are important to rule out other disorders like other infections or sepsis and those types of things. And then some of the markers are important to kind of let you know that this inflammatory issue is going on in these patients. So you have to look at every single patient individually, and you have to go through this kind of exhaustive checklist. 1, make sure that there isn't any other problem. 2, then make sure that to check to see if they're having this inflammatory problem. And then if they are, then you have to kind of watch them very, very carefully. And
so
what we've noticed,
if you're having the inflammatory problem, that's why I don't know if you're a believer in this or not, but why hydroxychloroquine might work with some patients and not with others.
Yeah, it's possible. I just think probably it wasn't a strong enough anti-inflammatory. It wasn't a strong enough immunosuppressant. And there's a lot of research. There's a lot of articles that came out and said that. And at this point, we're not really using azithromycin anymore, and the hydroxychloroquine from system-wide has been kind of on an as-needed basis, an individual case where you can discern whether the patient needs it or not. But the important thing was that, when these patients had these inflammatory markers that were elevated, if you follow them very closely, you saw that, a minority of them do have this problem where all of a sudden they rapidly, get much worse. And they go from needing very little oxygen to needing to be intubated within a 6 to 12-hour process. And this was the exciting part, where we can, before getting to that point, before needing to be on a respirator, we started treating them very aggressively with anti-inflammatory medication, with strong immunosuppressive medications, which is kind of counterintuitive, right? You think that this patient is here, they have a virus, it's a deadly virus, it's killed, 200,000 people across the globe. But now, instead of treating the virus, you're actually giving medicine to suppress the patient's immune system, which is something that's really counterintuitive. But that was what worked for these patients. We were able to now, instead of putting those patients on a ventilator, we were able to give them the medicines, act fast and early, which is, I think, very, very, very important, to detect it early and to treat it early. And then at that point, we're able to prevent them from needing to go on a respirator. And that's what really has changed everything around for both of our hospitals over the past month.
So why do you think more people haven't discovered this protocol? Or are you getting calls from people, from other doctors and hospitals?
I am getting calls from other doctors, and the calls, I would say, are kind of 50-50. There's a lot of doctors who, unfortunately, are looking for a quick fix, right? So what's the one test? What's the one medicine? And that's the one thing I can't stress any harder to you and your listeners, is there isn't necessarily one test, and there isn't any one particular treatment plan. Every patient has their own kind of individual disease, and we've had to treat every single patient, now probably going on 30 to 35 patients that we've treated actively with this, with a different regimen. Not everyone, you can't treat everyone with the same treatments. There isn't a one-size-fits-all for this disease. You have to do your due diligence. You have to look at the patient in front of you, and then, come up with a treatment for the disease that patient is manifesting. You can't just go through the ICU and start handing out these medicines. If you give this medicine to someone who doesn't need it, you will surely kill them. So now you have to go through, you may have 10 patients in the ICU, and maybe 3 of them, maybe 6 of them have this, but the other 3 or 4 do not. So you can't just sit there and give this to everyone. You have to go through the process with each and every one of these patients and figure out what's going on with them, and then come up with the correct treatment for them.
One last question, Doctor, and that is, last weekend, 2 ER doctors from Bakersfield, they have seen more than 5,000 coronavirus tests. They held a press conference. The local media covered it, and they reported their findings and said the coronavirus is similar to the seasonal flu for the most part, and quarantine is not helping build a herd immunity. And they were confident that reopening was safe, but it was their personal opinion. This now has gone against what sounds spooky to me, the authoritative truth. And yesterday, the American College of Emergency Physicians and everybody else hammered them for this, for coming out and not walking in lockstep, and YouTube removed their video, saying that it was not part of authoritative truth. Does that concern you at all, that we are silencing people that might disagree, but are not, quacks?
Yeah, I think anytime you suppress someone's freedom of speech and their thought, then I think that's dangerous. So I think, especially from physicians who are on the front line, they need to be able to, get out what they're thinking, what they're seeing. I think once you start suppressing that, it makes it very, very, very dangerous. The one other thing, Glenn, I wanted to kind of tell you, which is something that we've learned over the past week, is that so this virus not only causes the infectious disease, okay, which usually manifests in the first week, but the more important thing is it causes an autoimmune disease. Okay, now the cytokine storm is one part of it, but the autoimmune disease that it causes could be anything. So now you're reading about all these people who are getting blood clots, which are not responding to the common therapy, or people who have strokes, or people who have Guillain-Barré syndrome, which is a neuromuscular disorder, or people who develop myocarditis and cardiomyopathy and have sudden death. These are all an autoimmune disease that this virus triggers. Now, this isn't an unknown thing. We've known that viruses can trigger autoimmune diseases in the past. It's just that this virus does it at an extraordinary pace. It does it in a significant amount of the patients that we're seeing in our ICUs. And I think this is the part that I would like to get out, is that I don't think the doctors are recognizing that, besides the virus causing damage, it's triggering an autoimmune disease. And it's the autoimmune process that's causing all the other parts. And it's important because – I'm sorry, go ahead.
No, go ahead. Quickly finish. I'm sorry. We're just running out of time.
Of course. It's the autoimmune process that if we can detect early, we're telling all these patients to stay home, and then by the time they're coming in, they're too sick. We're missing the part where we can pick up the autoimmune process. If we can detect it early, we can intervene early, we may be able to save a lot of these patients and maybe drastically change what we're doing in terms of, having patients stay at home, having everyone be quarantined, and all those kind of things.
Great. Dr. Tom Yadegar, the ICU director, Providence Cedars-Sinai Tarzana Medical Center, thank you so much for speaking out, and thank you for sharing this information. And congratulations to all of the people that you work with on doing such an amazing job, not having any of the patients on a respirator, and so far you haven't lost a patient. Good job. Thank you so much. God bless.